Thanks, Rashana. That's great. Do we have our live stream group? Excellent. Well, I'll kick things off. Welcome, everyone. Delegate Rodney Willett here, chair of the Behavioral Health Subcommittee here in the House under HWI, and it's an absolute pleasure to have everyone on the line on the call this afternoon. Really important issues of the day, and I appreciate you taking your time. There's never not a busy season, it seems like these days, but if we've learned nothing else in recent times, behavioral health is absolutely critical, should be, and it is a critical focus right now. There were issues we were dealing with before this whole pandemic started, and a lot of those, of course, have been exacerbated by the pandemic. And I think that's why the work of this subcommittee is more important than ever. And so I really appreciate everyone joining us this afternoon. Just to sort of frame things up as to why we're here, this is, I think, arguably one of the most important things we can be looking at right now. A lot of people are calling the impacts of the pandemic, the fourth wave. And I think that, unfortunately, is true in so many ways. When you look at the statistics, the number of folks who are really struggling there. I've been particularly focused on sort of two areas myself personally. That is at the adolescent level, as kids have come back into some level of the school environment. Lots of concerns there. I'm hearing from parents, teachers, health professionals, pediatricians, psychologists, psychiatrists who've talked to these students, and that's the ones we know about. And I think the concern is there are a lot of kids we have not seen for a long time, so there's certainly concern there. Other people, non-adolescents, are struggling too with so many issues related to the pandemic. Probably the most troubling number I've seen on that is in the opioid abuse, substance abuse area. Just terrible there, and what's happening, and the increase in overdose deaths. Even here in Henrico, just this huge spikes there. Talked to our chief of police about that, talked to healthcare professionals about that. So it's obviously related to the pandemic, and it's certainly something to be aware of. But a lot of the issues that this subcommittee has been dealing with were issues before we got the pandemic. So I think, again, it makes our work even more important in terms of trying to address that. That's why we're so fortunate to have folks here today. So just to frame things up a little bit, we are not here to supplant the efforts of other groups. I know the Deeds Commission has been meeting very recently this week and continuing its good work. There are other groups led by Senator McPike, who has a study group on discharge planning, another critical part of this equation. There's Delegate Bell's supported decision-making agreements group. What that illustrates is that there's a lot going on here, and we're trying to share updates on the good work that the state is doing, and obviously to have a discussion about that progress, and then also to ask questions, make suggestions where we can. So again, I appreciate everyone coming together today. Wanted just to quickly thank folks who made this happen, starting first of all from my chief of staff, Colleen Grady, who's worked for hours, days, months, weeks to get us all together. So thank you, Colleen. We know we can't have a meeting like this without Sarah. Sarah Stanton is just outstanding as our counsel, and really appreciate her being here. And I'm like a lot of folks, I can't get used to seeing Sarah without her cat in the background and her wonderful plants. So we'll have to do something about that in her General Assembly office there. But that's okay, Sarah. We still love you and having you here. And I really appreciate. I'm going to start at the top with Commissioner Land from Behavioral Health. We've had multiple conversations throughout, before the pandemic, but certainly during the pandemic. And she and Alex Harris from her team, Josie Mace, they have just been great to pull this together. We're going to hear from Behavioral Health, but really appreciate their efforts on this. I mean, they were juggling so much before, and obviously their plates have just gotten more full. So I really appreciate them coming in. So just for the format today, we're going to have three speakers, and we're going to start with Mira Singer from behavioral health, and talking about Step Virginia and an update there. We've got Heather Norton, who's going to join us and update us on the crisis system transformation. Really exciting progress there, and things that are being done. Heather's also with behavioral health, and then finally Dr. Alyssa Ward talking about Project Bravo. And what we'd like to do after each presentation is have just a brief discussion. Obviously, questions are welcome, comments are welcome. We're not necessarily going to solve world hunger today or the behavioral health crisis, but I think we can at least put these issues on the table, get an update, and then make sure we're aware of what's going on. So before we start the speakers, I also just want to recognize members of this committee, and I know folks are juggling a lot of things these days, but my good friend Delegate Sia Price is on with us right now. I think we'll be joined hopefully by some of the other members. I know they all are focused on this. Certainly Delegate Head, Delegate Bell, and then Patrick Hope, who I think has been, he's already been with Sarah for 3 meetings, I think, this week already. So I know they are absolutely joined at the hip in these endeavors. We may be joined later by Chairman Sickles, who also is jumping from several meetings related to these topics, and then my good friend Mark Levine. So with that, why don't we turn things to Mira? And again, thanks for everyone for being here today.
Okay, can you hear me? Okay. Let me make sure I've got the gallery view. Okay. All right. And I think the way we're going to do it is Heather is going to advance the slides. She and I put our slides together. So Heather, I can't actually see on this end. So
I need access. I need permission to share screen first so that I can share the slides.
Gotcha.
You should have been, you're a co-host now, so you should have access to share now.
Okay. All right. Let's see. There we go. Okay. Delegate Willett and members of the subcommittee and guests and participants, thank you so much for the opportunity to speak with you today and to present with you today. We're really glad for the opportunity, and just really excited to spend a little bit of time, and in particular your opening comments about the pandemic certainly rang true. Probably I could go ahead and speak for all of the speakers and the agencies. So I'm hoping to touch on those in a bit, just as they relate to these initiatives. And really glad to speak with you today, particularly about Step Virginia, and then I'll pass it off to my colleague who will talk about the crisis systems transformation. And then, of course, as you said, Dr. Ward, related to Project Bravo, also known as behavioral health enhancement. I think one thing we are hoping to share and provide as a takeaway is that in terms of these initiatives, these state level initiatives, even though they are somewhat separate presentations, they're very much inherently interrelated initiatives aimed at building capacity within the public and private behavioral health systems, focusing on early intervention and prevention across the lifespan, improving the quality of services, supporting people in the least restrictive settings, and of course, of great importance to this subcommittee and to many, many stakeholders, over time, shifting the behavioral health system to one that's more reliant on community-based settings and less so on high acuity services. So with that in mind, we'll go ahead through. Heather, if you want to shift to the next slide. So wanted to touch quickly, somewhat briefly on just in terms of context DVHDS's priorities. We have, recently made an effort to collate these into sort of this infographic here in front of you. So we think you will recognize these strategic priorities due to the work that has been underway, certainly over the past number of months, but also, many years. And also, of course, the support from, this body and other bodies in particular. So, these are not in priority, but we wanted to, nonetheless capture them for your, your viewing and your attention. We'll be focusing primarily on, that third bullet related to rebalancing the behavioral health system in our presentations today. But again, these are highly interrelated, especially as related to the hospital census and modernizing systems as well. But again, wanted to place them in the context of the overall areas that our agency is working on. So next slide, and again, Delegate Willett, your comments about the pandemic, I think really rang true to us, or I guess, speaking for myself, but probably for the group, and, kind of wanted to, I think, contextualize the work of STEP Virginia and also the crisis system work a bit. It just feels, pretty relevant, obviously, to, kind of touch on the impacts of the pandemic, as well as I'll be speaking briefly about the needs assessment, which we conducted in, actually was in 2019, right before the pandemic hit. But the impacts of the pandemic, which highlighted several key considerations for thinking about systems transformation, which ultimately, of course, STEP Virginia and crisis systems are seeking. And these relate primarily to the importance of infrastructure in the behavioral health system, such as typically available staffing and services, having reliable access to services, even, in the face of a pandemic, equipment, systems, and tools that, keep the daily business going. The pandemic also really highlighted the need for flexible and adaptive systems of care, primarily that help people who are receiving services and their natural supports at the center of operations and decision-making. And it also, really elevated equity and prevention and community-based behavioral health responses to the forefront. So those are some of the impacts, we think related to the pandemic that are also themes, we are finding throughout STEP Virginia systems transformation, and certainly were echoed in some way in a needs assessment that was undertaken in 2019 and is still highly relevant. So just wanted to touch on that for a moment. And then Heather, next slide. So again, just kind of, again, sort of further context related to COVID and, mental health, you put it very, very well in terms of the health impacts, social isolation, certainly a range of, behavioral health, mental health, psychological impacts that, frankly, I think we collectively are really just beginning to understand, exactly what the impacts are in terms of, what the long-term impacts are, what the needs are, but, nonetheless underscore the importance of moving ahead with ongoing initiatives and providing access to a rapid, and supportive delivery system, while also in parallel, gaining clarity about many new and emerging needs related to the pandemic. So, certainly lots to uncover in the way of understanding and responding to the new and ongoing needs. Next slide, Heather. So we were asked to speak a bit about a needs assessment. So wanted to, kind of touch on this briefly, and then, kind of head into some of the more sort of step-by-step updates with STEP Virginia. So we engaged in a needs assessment. It was conducted throughout 2019. So, prior to the pandemic, we did engage with a firm called JVS. This is a well-known, reputable national firm. They are in the business of comprehensive behavioral health needs assessments. And generally, the reason for this assessment was to assess the current capacity of the public system to meet the behavioral health needs of Virginians across the continuum, and to use that information as a basis for understanding the context of systems transformation underway, namely STEP Virginia, and to really guide future systems improvements and to help plan for the future. So again, this was conducted pre-pandemic throughout the course of 2019, and the final assessment was issued, I was just looking at the date, March 18th, 2020. So that was, I think it was about a week or so after the public health emergency, or roughly around there, was issued. So certainly, quite a bit has happened since that time. But, nonetheless, there's quite a bit of relevance pertaining to the needs assessment findings. And if you think back to, the 2019, 2018, 2017 time period, really at that time, the behavioral health system was in there were sort of many early stages and a number of stages of various system-wide changes. The onset of STEP Virginia, which was, a very significant path to shifting from 3 core services within the public system to 9 core services. The onset of ARTS through the Medicaid benefit, expansion of Medicaid, the carving of behavioral health services to 6 MCOs, a number of efforts underway. So it was in this context that the needs assessment was completed and finalized. So a number of very critical findings. And essentially at the core, it found that STEP Virginia has increased, and this was pretty much in the early stages, it has increased access to behavioral health services, and that ongoing investments and implementation would continue to build capacity and build infrastructure, critical infrastructure, to support Virginians. And at the same time, there are other supportive, kind of adjacent fundamental changes to underlying systems that really also must be addressed in order to fully realize the potential of STEP Virginia, especially in the new environment, because the first 2 steps of STEP Virginia were, sort of launched and then came online, if you will, as Medicaid expansion was coming online and the MCOs were emerging as well. So the broad themes are here in the slide, and they relate primarily to modernizing data sharing and health information technology, strengthening infrastructure and administrative capacity within the behavioral health system, primarily within the CSBs, to thrive in the managed care environment, payment and financing reforms to support evidence-based practices, which is very much where behavioral health enhancement, comes into play. And then also identifying and investing in a range of workforce supports, particularly to recruit and train high quality workforce. So a lot of information there, but I think if you could, keep in mind, great strides, increased access, and great opportunities to continue building and strengthening infrastructure, I think are the main takeaways. Next slide, Heather, please. So this brings us to some of the nuts and bolts, I think, related to STEP Virginia. So just a little bit of overview. STEP stands for Systems, Transformation, Excellence, and Performance. And this is Virginia's concentrated effort to reform the public mental health system by improving access, quality, accountability, and consistency in mental health services across the Commonwealth. And when we say, just sort of as a point of clarification and sort of level setting, when we say public mental health system, we're really referring to the 40 community services boards, which are, of course, the agencies established by local governments to administer mental health, substance use, and developmental services in their communities. So in 2017, changes were enacted to code to expand the core services to community services boards to include essentially additional services, same-day access, primary care screening, crisis services, outpatient services, psychiatric rehabilitation, peer support, and family services. And this is available on the next slide, so don't, or I know you have this in front of you, veteran support services, care coordination, and case management. So prior to that time, the boards were statutorily required to provide only 3 services. So these new services are collectively called STEP Virginia, and they're all required to provide them by July 2021. So broadly, STEP Virginia was envisioned to build upstream capacity within the behavioral health system and support capacity and infrastructure to do so. It was, recognized that the system was overall, highly reactive, and capacity was largely geared, at very sort of high acuity, crisis-oriented end of the continuum, and so thus began a comprehensive shift system-wide. So not only with STEP Virginia, but then of course also with other initiatives that have been mentioned previously, the arts benefit, reimbursement for peer recovery specialists, and so forth. So, we like to sort of conceptualize and say that the mission and intended outcomes is that after full implementation, along with the other initiatives that you will hear about today, and that I think is really critical. I think it's really excellent that these presentations are paired together, including behavioral health enhancement. Again, thinking about Medicaid as the largest payer of behavioral health services. Upon implementation, of STEP Virginia and some of these other initiatives, we really have a vision and a mission of fewer admissions to state hospitals, decreased emergency room visits, reduced involvement of individuals in the criminal justice system, and so forth. And trying to be mindful of time, but I think we're okay. So I did want to say one thing about STEP Virginia, that it was based off of a national model called CCBHC. This stands for Certified Community Behavioral Health Clinics. This was a model coming out of SAMHSA at the time. And there were a couple of key differences in the Virginia sort of version of STEP Virginia and the national model, but namely related to reimbursement and enhanced reimbursement. But in general, the intention was to set out a framework and to mandate access to core services. So next slide, Heather. So this is, again, the kind of the 9 services laid out. And then if you look at the, kind of steps, the green steps are the ones that have been implemented. The blue are underway, meaning funding has been allocated and plans have been developed and implemented. Services are being stood up or are stood up. Purple is recently funded and being readied for implementation. And then orange, future steps are not yet funded. Next slide, please, Heather. So I know there's quite a bit of information on this slide. We wanted to show you the timeline, the funding status, as well as the funding level that was reallocated following special session for FY22, and where we are with the phases. And wanted to spend just a quick minute on that related to the phases. So we generally refer to 3 phases. So initiation, preliminary implementation, and validating program outcomes. So this tends to answer the question, where are you with the steps? What is the status? So phase 1, you could think of as the planning for services and metrics are completed and technical assistance is provided. Phase 2, you could think of as, that's the start date. CSBs will have begun implementation, partially running at a minimum. Problems and barriers are identified and solved with, for example, collaboration, best practice sharing, technical assistance. Metrics are implemented, and by the end of phase 2, collaborative benchmarks are set up and considered reliable. And then when we get into phase 3, that's when we are looking at outcomes and goals are monitored and reviewed collaboratively. So, really into the quality improvement process. So the next few slides will touch, sort of on that question of, so where are we with these steps? Tell us a little bit about each step, and what are we learning? What do we know? So hoping to provide some information to you about these steps. So the way they are set up is that the objective is on each slide of, so for example, same day access, the objective, that's, what does this slide mean? What is it intended to capture? So with regards to same day access, a few kind of highlights. This is well underway within all boards, currently available to all at 70 locations throughout Virginia, satellite sites and so forth. And throughout the process of establishing this, the boards worked with a national consultant to adopt practices that would essentially enable them to see a person who arrived or called for services that very same day. So collaborative documentation, centralized scheduling, engagement of the individual, adopting certain business practices and things of that nature that would allow them to engage in same day access. So all CSBs are reporting data on same day access, assessments completed, first appointment offered, and appointment attended on a monthly basis. And probably would be helpful to help explain that benchmarks were set prior to implementation that focused on an appointment being offered within 10 days for 86% of people in need of services, and that 70% of these individuals would be seen within 30 days. So we are at the point in the phasing where the quality improvement process is beginning July 1. So that's where the outcomes will be reviewed and analyzed. But preliminarily, the data is showing that these benchmarks are being met. And we certainly would look forward to coming back or sharing more information as that quality improvement process gets a little bit more underway. So Heather, next slide. I probably am not going to spend a whole lot of time on these two slides. I think the takeaway here, we did qualitative check-ins with all of the boards, and this was prior to the pandemic. So this really is sort of summarizing the findings related to strengths and needs. I think it is important to share that there were a number of pivots, if you will, during COVID, and that, largely same-day access services were, upheld and provided in many instances, very kind of innovative ways during the pandemic. Drive-up services, many incorporated COVID screens, obviously, telehealth, and so forth. So, I think without spending a whole lot of time on the next two slides, they provide a summary of the concerns and strengths, and we will shift back to qualitative check-ins throughout the length of the implementation process. Next slide, please. Actually, Heather, if you want to go to the one that says primary care screening at the top. So this step is aimed at populations served by CSBs who are known to be at higher risk for poor physical health outcomes, largely due to unidentified chronic conditions, and thus often have a shorter life expectancy due to these chronic conditions and other related factors in terms of access to services and stigma and things of that nature. So the goal here is ensuring access to screening and identifying and providing care coordination to ensure access to physical health care. So there were a couple of objectives related to primary care screening, targeting priority populations. And let's see, I think the next slide, if you want to go to the next slide, Heather, please. We do have, let's see, some information about numbers of screenings that were provided related to the different target populations. So during FY20, a total of about 78,000 screens were conducted for unique 36,000 individuals. And then for the other objective, 34,500 metabolic screens were conducted across 17,000 individuals. So, and then if you go back to the next screen, Heather. So again, we did do qualitative implementation interviews. There were a number of pivots related to primary care screening, which launched very shortly after shortly before the pandemic began. And I think, probably just really important to share that in-person screens were conducted in, many instances if the client presented in person, for example, if they didn't have a primary care screen, or any number of instances. So we are in phase 2, and, when we move into phase 3, we begin the process of validating program outcomes. So let's see, I think quickly touching on outpatient and then kind of rounding out the other steps. So outpatient services was initially funded in, let's see, FY20 with an initial round of funding that supported a tremendous scope of infrastructure and capacity for the boards. This really represented quite a significant shift for many boards that traditionally many did not have dedicated traditional outpatient therapy capacity, or did not have dedicated capacity for certain populations, especially youth and young adults. So CSBs were expected to balance investments across mental health, substance use, child and family services, and ensure capacity across the lifespan. Additional funding is allocated for FY22 and being ready for distribution. And there was also a portion of funding to support training and capacity building in evidence-based practices as well. Next slide, Heather. My colleague Heather will touch more on mobile crisis and crisis dispatch in terms of the relationship with the comprehensive crisis system. And so I think this is definitely one of the ways in which Step Virginia and certainly comprehensive crisis and also behavioral health enhancement are highly interrelated to align and build capacity and really shift the system to support people in their communities. But wanted to briefly touch on mobile crisis and crisis dispatch within Step Virginia. These are very critical community-based services to reduce the use of hospital emergency departments and provide immediate crisis intervention in the home or in the community, not in the hospital, not in an emergency room, not in a police station. So we're very, very, very excited about the advancements and infrastructure being built related to mobile crisis and crisis dispatch. Next slide, Heather. And we were grateful for funding in allocations in FY20. Also, funding was reallocated following special session for FY22 to support the development of teams, which are underway in all regions of the Commonwealth. And again, these teams provide direct services to stabilize the individual and may jeopardize their current community living. We are in the process of reviewing plans and staffing, and would look to have updated information to you, perhaps in a future meeting related to the staffing. And as well, funding was appropriated for dispatch staff to support the transition to call centers, which is a key part of the comprehensive crisis system work. So last but not least, I wanted to touch on real briefly and then turn it over to Heather. So funding was appropriated in 21 and 22. I'm sorry, funding was appropriated, yes, for FY22 for as well for service members, veterans, and families, and peer and family support services. So these are two of the steps that are being readied for phase 2, July 1. And so here is the sort of the overview of SMVF, which will support dedicated capacity and infrastructure, and really features primarily clinical services enhancements, military cultural competence expectations, and collaborations with a number of external providers and partners. And then next slide, Heather. So peer and family support services, again, the objective here is supporting the addition of peer support specialists or family support partners at every board to be integrated into appropriate ways in the service delivery system, as well as enhancing systems improvements, including developing infrastructure that supports sustained billing, Medicaid billing of peer and family support services. And we will be starting phase 2 of this implementation July 1, 2021. So we are getting ready for this step of Step Virginia. And then next slide, Heather. So I think, so taking it from that very granular level, then back, kind of to the 30,000 foot view, if you will, in terms of, some of the next steps. Broadly, the next steps within Step Virginia are launching the implementation, as I've kind of shared in some of the previous slides related to phase 2 and some of the steps that are just coming online, July 1. Continued planning of the remaining 3 steps, so care coordination, case management, and psychiatric rehabilitation, as well as the ongoing coordination and integration with our sister agency, DMAS, related to behavioral health enhancement and comprehensive crisis system. And then Sort of going back to the findings of the needs assessment, undertaking infrastructure improvements related to health information technology and, other areas in order to ensure we have the resources and capacity needed to, fully capitalize on the promise of STEP Virginia and achieve its full potential. So with that, I will either turn it over to you, Heather, or Delegate, if you, wanted to do questions now. Happy to take your lead on that.
Mary, thank you so much for that. I guess we could do this check quickly for at least the participants here. If we get a raised hand and on the screen here. I think actually I see Delegate Hope's got a raised hand there. So why don't we take a few questions here? That was a great presentation, but we maybe want to digest it a little bit with a few questions. So let's do that first, then we'll move on to Heather.
Thank you, Mr. Chair. And I was asking the question related to the exercise we're going through now on the ARPA funding, and whether or not, because I don't know if these funds lend themselves to one-time money. But if the anticipation is that we're going to be asking for more money, is there a way to speed any of this up to put those monies in place sooner with the ARPA money? Is that something that the department has thought through?
Yeah, that's thank you, Delegate Hope, for that question. So, of course, are you referring to there's the block grant ARPA funding or the kind of the state ARPA funding?
Yeah, I mean,
or ARPA, just in general, kind of the ARPA funding in general. Well,
maybe it's either or. I mean, I was thinking the state.
Yeah,
it could certainly be either or. I know there's block grants money available too.
Yeah, so absolutely. I mean, there's no doubt it's a tremendous opportunity in terms of the infusion of funds. I think we're very interested and, eager to have conversations with, the General Assembly and certainly, of course, the administration about the best use of these funds. So, I think in general, we would want to look at, strategies and the use of these funds to address systemic needs and, infrastructure needs in general. Because it is our understanding that these are one-time funds. And so, I think probably a question is, what are the opportunities there to, leverage these one-time funds to, really achieve some significant impacts that have, probably eluded us all in the past. So I don't have a, perfect answer. I think there are a number of exciting opportunities and, certainly look forward to any discussions that, we might be able to be part of related to, just sharing ideas or things of that nature. But it is our understanding that these will be one-time funds.
Mary, we also get a question from Emily Griffey with Voices for Virginia's Children.
Hi there, it's Emily. Thanks for having this forum today. I just wanted, a thought came to mind in particular around ARPA funding and with the next two steps to roll out being care coordination and case management. One thing that I think we see as a particular challenge here is the workforce challenges right now and the real need to help families navigate systems and find supports that work for them that may not currently fit within our system. So I see potential questions about reimagining what care coordination and case management look like as potentially useful next steps for us to be looking at in this field, as well as using some funds to design consumer participation in that process, like hear youth and family voice in designing those next steps as well. So just wanted to throw that out there as an idea, and it might be something for this group to look at. What are those best practices in care coordination and case management? If there are one-time funds through ARPA, whether it's technology, training, evaluation of pilot efforts. Those could be certainly some useful tools to make sure that we maximize our system capacity during this time too.
Hi, it's Allison Land. I was just going to chime in with Mira. We have all agencies have been asked to put together kind of what we're thinking for those ARPA funds, and we have submitted. We don't know what they're going to approve us to move forward with, but you can be assured that we're going to be looking at ways that we can continue to develop Step Virginia and implement Step Virginia as part of that. What we're going to request. We may not be given it, but we're definitely going to ask to be able to move us forward and really make this transformation occur.
Great. I see a hand from Delegate Price.
Yes, thank you, Mr. Chairman. And this is for Dr. Land or Mira. But I know that you were saying that the needs assessment was done prior to COVID. And I didn't know if you could even anecdotally tell us some of the things that may have changed. I do remember in some of the presentations that you all were talking about innovation and a lot of creativity that it took to get through COVID. And I was hoping to see if there were some of those measures that you wanted to keep, or if there were lessons learned that you could share. And if not at this moment, will there be an opportunity to kind of do like an addendum to the needs assessment post-COVID so we can have a more full picture?
Yeah, thank you, Delegate Price. I love that idea about an addendum. I don't know that we had thought about it necessarily in those ways, but I think it's an excellent idea, and one that I think we'll certainly want to look at. I think in general, what is interesting is that there were some very relevant themes related to the needs assessment that, I think even though the assessment was, honestly, it feels like a lifetime ago because it was prior to the pandemic and that, everything that has ensued since then. The major findings, still seem very relevant. And if anything, were probably underscored as related to the pandemic. So for example, the need to have, very strong infrastructure within, for example, public service providers or community-based providers in general, whether in the public or private realm, the ability to enhance and utilize modern data systems and health information technology, sort of the days of workarounds, if you will, really ought to go by the wayside because in, for example, times of emergency, as we found in the PHE, every moment is precious in terms of healthcare delivery. And so while it may be acceptable in some instances to have, such workarounds or what have you, we really ought to look at every opportunity to integrate, for example, health information technology or electronic health records, to ensure that the person is really at the center and that systems work seamlessly. So, and then I think probably third would be related to, workforce, supporting workforce, identifying ways to invest in, workforce, support the workforce. So I think, overall, we will need to do kind of a deeper dive and take a little bit more time to look at the findings, kind of crosswalk them, if you will, to what we know about the pandemic, and kind of, really wrap our minds around what is our lessons learned or relevant. But, I think our gut is that, it's really the core infrastructure, capacity needs, kind of front-loading prevention, front-loading the ability to have a community-based response, flexible delivery systems, things of that nature. And I would say those were all themes that were, echoed in the needs assessment.
Thank you.
I want to get to Heather, but Kathy from NAMI just raised her hand, so I don't want. This is all about conversation. So, Kathy, if you want to go ahead with your question.
Yes. Hi. Thank you. Thank you, Mira. Great job. The state has done a phenomenal job in reaction to everything that's gone on. But the actions that have been taken by all of us really have been as a reaction to the event, the pandemic. And so everything that you've said is to kind of prepare us and to continue to move us forward in a positive way. Has the state developed a continuity of operations plan or COOP to ensure that services are carried out in the most effective way moving forward during, another emergency, any wide range of emergencies that might come up?
Yes. So, we think you're exactly right in general. Hopefully collectively the speakers will, present the concepts of moving from a more reactive to a more proactive system overall. So that certainly is the goal. And then in terms of a COOP plan, yes, our agency certainly has a COOP plan. In fact, I think it's probably required by all agencies. And then, certainly the local, community services boards by their governing entities, the localities, I think that they're probably required to have those as well. So, I think we all learned quite a bit during the pandemic related to these COOP plans and, the strengths and weaknesses and opportunities for improvement. So certainly lessons all around, but yes, we certainly have a COOP plan, and I believe all the boards do, related to the continuity of services. And, probably would be remiss if I didn't say that, the CSBs were all, they continue to provide code mandated services throughout the pandemic. They prioritized essential services, including, pre-screening, discharge planning, diversion, and so forth. And there were a range of other critical services that continued to be provided. But certainly the point is very well taken. And, again, I think the takeaway is, how important the infrastructure is and the need for flexible and adaptive systems to continue providing services.
Yes, thank you so much.
Excellent, Mira. Thank you very much. I'm going to pivot back to Heather. I realized, though, after I was doing my introductions, I had been talking back and forth with Rashana Senior, our clerk, and Rashana, I didn't give you a shout out for getting us all organized, so I'm giving you one now. Thank you very much for getting us live here and keeping this going. No easy task. Thank you. So with that, Heather, we'll kick it back to you.
Thank you, Delegate Willett, members of the committee and guests for the opportunity to present today on the exciting work the Commonwealth is doing with regards to crisis system transformation. Mira reviewed the agency priorities at the beginning of her presentation, and I just want to explain that crisis system transformation really intersects with all of our agency priorities, as well as the work that the agency is doing related to the Marcus Alert and the work that DMAS is doing related to Project Bravo or behavioral health enhancement. The existing behavioral health crisis system in Virginia has multiple disparate ways for people in crisis to access care and multiple ways for the people who are staffing the crisis system to receive, assess, triage, and record these calls for care. Local community service boards, behavioral health authorities receive calls through more than 40 distinct telephone numbers bifurcated by disability, age, and even specific crisis situations. For example, there are currently 3 separate National Suicide Prevention Lifeline crisis call centers here in the Commonwealth. This patchwork of access points is often confusing to the person who is in need of crisis services and creates multiple hurdles to access help and get appropriate care instead of a single point of entry that is outside of 911. Excuse me. So with crisis system transformation, our focus has really been on the development of a community-based, trauma-informed, recovery-oriented crisis system that responds to crises where they occur and to prevent out-of-home placements for individuals. A comprehensive crisis system really focuses on 4 key features, as is demonstrated here in this slide. Those 4 key features are a high-tech crisis call center, access to 24/7 mobile crisis care, crisis receiving centers that comprise a no-reject drop-off, access to 23-hour observation, as well as crisis stabilization beds. And then also essential principles and practices which focus on and include recovery orientation, trauma-informed care, a significant use of peer staff, a commitment to zero suicide and suicide safer care, a strong commitment to the safety of the individuals we support and the staff, and collaboration with law enforcement. Our crisis system really is based off of a national best practice, Crisis Now model, and also aligns with the sequential intercept model with a focus for crisis system transformation on intercept 0. But the intersection of our sequential intercept model also with the work that we're doing under the Marcus Alert at intercept 1 with the work with law enforcement, really trying to get individuals back to intercept 0 into community services where that is possible and appropriate. With that, I'm going to review the different components of the crisis system that we're developing. The first of those is a data platform. The goal of the data platform is really to collect outcome data related to all components of the comprehensive crisis system. This is to ensure that we have transparency in our data and that the data informs us of what people are seeking and where they're seeking those services. The platform not only informs the system about where it's at currently, but also around future development. We are anticipating awarding a contract through an RFP within the next month and going live with the system between October and November, along with our implementation of our call center. The modules that are anticipated to be a part of our data platform are around intake, mobile crisis dispatch, a bed registry that catalogs the beds throughout the Commonwealth related to crisis stabilization units, our crisis therapeutic homes for individuals with developmental disabilities, and private and public psychiatric hospital beds. We're also securing an appointment scheduler that will help us link individuals to supports and services throughout their community. And then the data analytics component, as I mentioned, to ensure that we have comprehensive data, but also transparent data that helps individuals see how our system is progressing. As I mentioned, the first part of the comprehensive crisis system is the crisis call center. It is, along with the data platform, expected to launch in October or November. We are working to integrate our crisis call center with the federal legislation around 988, which requires each of the states to come into compliance with 988 integration by 7/16/2022. Our goal is to come into compliance early and be able to start that process in December. We're also working with our partners throughout the Commonwealth around the integration of crisis lines. As I mentioned in my introduction, there are multiple different ways that individuals access crisis services. But we do realize that the integration of these crisis lines and utilization of 988 in the crisis call center has to be a strategically implemented process so that individuals, in fact, are getting connected to the right supports and services at the right time, and to ensure the success of the crisis call center upon its launch. Additionally, our crisis call center will be integrated with the Marcus Alert, and through the Marcus Alert Planning Work Group, a 4-level urgency triage framework was developed, and the 4 levels are used throughout the state plan to support shared communication across sectors, so both across the crisis system, but then also around the in collaboration with the public safety answering points, to provide a framework for planning different responses regardless of who receives the phone call. Simultaneously, we will also be implementing a level of care screening that assesses individuals' safety and risk needs and connects them to the right services at the right time. The Crisis Call Center is intended to function 24/7, 365 days a year, and will be staffed by an array of staff, including licensed staff, qualified mental health professionals, peers, and volunteers, to assure that we can answer calls within an appropriate time frame. The expectation based on national data is that 80% of calls will be able to be resolved on the phone, while the remaining 20% will need additional supports and services such as mobile crisis, crisis stabilization unit, bed access, or in some situations, access to hospitalization. Part of our plan for the Crisis Call Center is to formalize the training for all call answerers, so that we will have a statewide training curriculum for the Crisis Call Center staff to assure that we have the best trained responders for individuals who are calling into the center in crisis. The next part of our crisis system transformation focuses on mobile crisis. We are in the process, as Mira mentioned in her presentation, of developing mobile crisis teams across the Commonwealth. We currently have 24/7 access for mobile crisis teams for individuals with developmental disabilities statewide. We have rolled out child mobile crisis teams, and this fall are working to roll out adult mobile crisis teams. Our mobile crisis teams are either single responder, if the individual is known to the system and has received supports and services before, or a dual responder where a licensed or a qualified mental health professional along with a peer or family support partner will respond in the community. Mobile crisis is also comprised of co-response teams, and those co-response teams can be of a formal nature. We have certain localities that already have police and mental health professionals responding in the community together, or they can be of an informal nature where the mobile crisis team can request through the call center backup from law enforcement in those situations where that is deemed necessary and or appropriate. As part of the co-response process and part of the Marcus Alert 4-level triage, we have determined situations where police may need to respond first if there is risk of life or serious danger related to weapons, and then where police may respond in tandem with the mobile team in order to support and assure safety. As I mentioned, we are in the process of building out our mobile crisis complement and integrating the different teams that we have together. Our goal at the department is to have mobile crisis teams that can serve individuals across the lifespan and regardless of disability type. The third component of the crisis continuum is a crisis receiving center. And we have all of the different components of what is a national best practice model of a crisis receiving center, although currently they are not all housed, if you will, in the same location. So we have our CIT assessment centers, which are provide police the opportunity to drop individuals off who are in need of screening and follow-up. We are in the process of creating and developing enhancing 23-hour observation access And of course, we have crisis stabilization units across the Commonwealth that serve adults and children in need of those supports and services. The idea of a comprehensive crisis receiving center is that it's a one-stop shop where all of these services are available and individuals can transition safely through them without having to travel between those locations. And so we are in the process of revisiting our current CIT assessment center structure and looking at how we can expand the services and supports that are available. It does not necessarily negate the need for the CIT assessment center in its current state. It is really looking at a combination of fully built out crisis receiving centers in different parts of the Commonwealth, and then satellite sites that offer maybe a complement of the services, but not all of the services of a fully built out crisis receiving center. As Mira mentioned during her presentation, there is a large intersection between the work of STEP Virginia, Project Bravo, and the crisis system transformation. And so when we're looking at crisis system transformation and the sustainability related to crisis system transformation, we're looking at a series of 3 different funding sources to ensure that we are meeting the needs of all individuals across the Commonwealth related to crisis services. And so under Project Bravo, we have redefined mobile crisis. We have changed the way that that crisis stabilization units get reimbursed. We have created a 23-hour observation reimbursement structure, and we have created a service called community-based stabilization, which provides supports and services to individuals as they're transitioning out of crisis and trying to get connected to long-term supports and services so that they are not continuously going in and out of a crisis cycle. In addition, during this last session, we're extremely grateful that the General Assembly approved the 988 tax, as this will provide additional funding related to the Crisis Call Center and support the staffing that'll be necessary to answer those calls according to the National Suicide Prevention Lifeline standards. And then finally, we currently receive funding for crisis services in a variety of different ways. We receive about $25 million in funding for the developmental disability crisis services, both the crisis therapeutic homes, the mobile crisis services, for children and adults, for individuals with developmental disabilities. We've received $7.8 million for children's mobile crisis, as well as a mobile crisis for individuals with serious mental illness who present with a cognitive impairment, but who do not meet the criteria for developmental disability services. This fiscal year, we will be receiving an additional $6.1 million to launch adult mobile crisis and $4.6 million to launch our call center staffing. And with that, I'm happy to answer any questions around our crisis system transformation that the committee or others may have.
Heather, thank you so much. That's awesome progress. Switch my screen around here, see if we've got any raised hands yet. Let's see here. I had one. I could start until I see a hand. One question, Heather, for the team there, in terms of, I guess it'd be the handoff from CST and Marcus Alerts to the community-based providers. So what's the vision there for how that works? I guess you call it the warm handoff with these folks.
I think that can happen in a variety of different ways, and we're actually, just in the planning stages related to that. We have done some meetings with Unite Us about how we connect the resources in the community to the platform so that the call takers have an array of services to connect people to related to, their preference and what they need. I think that what we have learned through the work that we have done. We've received 2 grants through Vibrant Emotional Health and have been working with our current National Suicide Prevention Lifeline partners. And not all individuals want or need ongoing supports and services, but may need to be connected to advocacy organizations, potential, private therapy or different things like that. And so what we want to do is make sure that we have a comprehensive referral database so that individuals can get connected to all supports and services that they might be seeking. I think the other important thing to note about that comprehensive database that we're trying to create for referrals is it's not just about mental health care, but it's about all levels of care and support, housing, electric. There's so many things that create a crisis for individuals, and we want to make sure that we can get them connected to all supports and services that they may need.
No, absolutely. Also curious, and I saw numbers there in terms of increasing your call center dollars to help you with your call center staff. Any projections yet on what that's from a volume standpoint, what that's going to look like in terms of number of calls?
Yeah, we have actually gotten some estimates from the National Suicide Prevention Lifeline about what they anticipate Virginia's call volume to be, and it's about 196,000 calls the first year is what they're anticipating.
Well, and is that? And then follow-up question is that in the realm of being manageable?
I think, the nice thing about the way that the 988 is structured is that it has a role, if you will, so that there are backups to the backups of call centers. And so we will be growing and learning as we implement this. The nice thing is because we are partnering with our existing National Suicide Prevention Lifeline partners in the Commonwealth, they have predictive models that they use around when they need to staff up based on call volume. We review data monthly in terms of what times calls come in, when we need to staff, how we need to staff in order to respond to those calls. I think one of the challenges that we will experience is really around the addition of text and chat, and how we manage that in addition to the call volume. So there's a lot of different factors that we'll be managing as we continue to go in there or go through this process. I think it's also why I mentioned that I think we have to have a strong implementation process around folding different crisis lines into that call center work so that we don't inundate or overwhelm the system as we launch that, and that we're very thoughtful in our implementation strategies as we go through this process.
Makes sense. Thank you. I see a hand up from Chairman Sickles.
Thank you, Mr. Chairman. I just wanted to ask Heather about now that she's had more time to get this program and shaped up, whether the money that we provided in some areas might be too little or too much. Could you reflect on that? Just now that you've spent more time thinking about what you're going to be doing here?
Yes, thank you. I think I want to start by saying we're extremely grateful for the funding that we've received because we're excited to launch this. We do recognize, however, that we will need additional funding in order to assure that we're providing 24/7 coverage across the Commonwealth. And so we recognize that there will be a need for additional funding. We are going to use the data within the system to really inform that and to make sure that we are utilizing our funding in the most efficient and effective manner in terms of where it's needed, where the calls are coming in, and also assuring that we are staffed according to utilization. And that is one of the advantages of having this comprehensive data platform, is that it will really inform how we staff and when we staff the system across the Commonwealth based on the type of calls we're receiving and who needs those supports and services, and then what kinds of supports and services they will need. But I do anticipate that we will need additional funding to ensure that we have 24/7 coverage across the Commonwealth.
Okay, thank you. Thank you, Mr. Chairman.
Thank you, Heather. Thank you again. Great job on that progress. I want to keep us rolling along because we do have one more presentation, and again, I love the questions and the discussion here. So, Dr. Alyssa Ward from DMAS is going to take it away.
Thank you so much, Mr. Chair and delegates, for having me here. I am wondering if someone, either Troy or Sarah, can make me a co-host on my non-camera identity so that I can share my slides through my computer screen.
Yes, I think we're going to need Roshana to help us with that.
Is the 804 number, is that your number?
No, there's two Alyssa Wards. There's one where you can see my face speaking, and then there's one that just has Alyssa Ward. If you could make that one a co-host.
Troy, could you make the other Alyssa Ward a co-host, please?
Repeat that, Roshana.
Could you make the other Alyssa Ward account a co-host? Okay, you should be good to go.
Okay.
Thank you.
And this solved one mystery, because I wonder how Alyssa gets so much done. Well, there are two Alyssa Wards, so now we know.
There are. That really is the answer. All right. Well, I'm going to put this. There we go. So again, thank you so much for having me here today. And I'm going to be speaking about actually our joint implementation between DMAS and DBHDS of the Project Bravo initiative, which stands for Behavioral Health Redesign for Access, Value, and Options, also known as Behavioral Health Enhancement. As I hope that most of you are familiar with now, this Project Bravo enhancement is really, it is a dual agency initiative that is meant to work together to build out a fully integrated continuum of behavioral health services within the Medicaid benefit. And we really are looking to infuse services into our benefit that are high quality, that come from the evidence of what we know works, that are trauma informed and cost effective, acknowledging the role that we play in the use of public funds and responsibility for those funds. And the Project Bravo initiative is one that was reallotted during the special session of 2020. And so we're going to be talking a little bit today about how the implementation has changed and giving an update on how this overlaps with a lot of the topics that you just heard about from DBHDS. So this picture that you're seeing now, some of you may have seen before, this is a representation of our current continuum of services in the Medicaid behavioral health benefit. So as you can see, as is illustrated here, our community mental health and rehab services represent our most intensive group of services that folks are able to participate in through Medicaid. These are very high intensity community-based services that require really significant acuity of symptomology in order to qualify for the services. There's also a really minimum amount of evidence-based practices that are implemented and within the Medicaid system. And we also don't have rates that really reflect the cost that it takes to implement evidence-based practices in a sustainable way. We have this over-reliance on intensive services for acute problems, and that is in part a result of, or I should say, that reliance on acuity services as in some ways manifested what we have now in terms of the psychiatric bed crisis. So we don't have enough buildup in the area of prevention and early intervention. And so we're kind of always stuck in a crisis cycle in terms of how our systems and all the pieces work together. So the goal here overall with Project Bravo from the beginning was first to develop a North Star and to understand what does the Commonwealth really need in its Medicaid system in order to reduce the need for these psychiatric beds, to really move towards a system that's going to really promote recovery and wellness for our members. And so that was our first task. And so jointly as the two agencies, we work with the Farley Health Center for health policy. We came up with this kind of North Star vision for what that type of continuum would look like. Now, obviously, there's a big difference between this blue continuum that you see on the screen versus the purple one that we just looked at. And that really has to do with the diversity of elements and levels of care, but also the stair-step design of a system like this that you can see really allows for a person to step through services going up and down on the level of intensity based on where they're at in their recovery journey. There's also other services that we feel like should really be infused across the whole continuum. And those include things like behavioral therapy supports, case management, and recovery and rehabilitation support services. So this is kind of the big picture. And one of our other big tasks was that we really wanted to acknowledge and use all of the momentum gleaned from really great work that was happening in the Commonwealth and had been funded preliminarily to support behavioral health enhancements per se in other sectors. So one really good example of that is the Department of Juvenile Justice and the transformative work they did bringing behavioral health focused evidence-based practices into their population, which allowed them to actually close down two of their institutions, their kind of more institutional facilities, and really move it to preventive community-based services. And so those services that they used are part of what we're going to be implementing in Medicaid. And so this this wheel of alignment that we often refer to, we have our new logo for Project Bravo in here in the center, but it really represents all of the different good work that has gone on. Another one I really want to call out today is the arts benefit, because we have talked today about the opioid epidemic and how that epidemic has even worsened over the course of the last year and a half or so. And the arts benefit is a really good example of another quote unquote enhancement. So prior to the implementation of arts, as many of you know, we had a really limited number of providers in Medicaid to do substance use disorder related work. We had a very limited amount of services. And so when we brought on the arts benefit and the ACM criteria that went with it, and the new rates, this drew in a huge network that has really improved our ability to serve those who have substance use disorders. That has made a huge impact upon Medicaid expansion in terms of getting people the medical treatment they need. And I can't even imagine where we would be at this time with the way that the opioid crisis has worsened if we didn't have arts in place as a Commonwealth. So arts is a really good example of an enhancement that we did on that side. And Project Bravo is an example of an enhancement that we're seeking to do on the mental health side of the benefit that has really some similar goals. Mira did such a wonderful job today talking through the Step Virginia implementation. And so this is our construction foundation image that we'd like to show to represent kind of the metaphorical relationship between the great work of Step Virginia and the CSB system, and how that is really the foundation for the improvement of access and quality of services in the Commonwealth. And one of the issues we have to contend with in Medicaid is that, we heard today a little bit about the scope of the CSBs. Now, the CSBs serve about 20% of our Medicaid population's behavioral health needs. About 80% of our members' behavioral health services are actually provided outside of the CSB system, in hospitals, healthcare systems, and private providers of community-based services. And so we knew that we wanted to take and be inspired by that great work of Step Virginia and move those same principles out into the larger network of providers that are serving the Medicaid members. And so Project Bravo, represents this large vision, but it's really also a very specific and intentional set of 6 critical services that we put forward for funding that we're aiming to directly address the psychiatric bed crisis that brings us together again and again, seeking solutions. So these 6 services include partial hospitalization programs and intensive outpatient programs. Those are 2 step down or diversion services that are traditionally in a benefit plan that help to keep people kind of moving in and out of inpatient care and hopefully diverting a lot from inpatient care. Because partial hospitalization is a little bit like being in the hospital but not sleeping there. And so there are research studies that show that, good proportions of folks who are in an inpatient hospitalization voluntarily could actually be there at a partial level. They could just be there during the day and would have the same progress. So anyhow, we also have these in the arts benefit, but we don't have them in mental health. And so these two services made a lot of sense to bring into our benefit. And then the assertive community treatment is a true enhancement of a Medicaid service called intensive community treatment, which has been implemented for many years, largely through the CSB system. It is a really coordinated set of healthcare professionals that work together for folks in the Commonwealth who have serious mental illness. So these are people who tend to have a lot of fragmented services and a lot of different service providers, and also have a lot of different social determinants of health factoring into their lives. And so what ACT does as an evidence-based treatment is it bonds that treatment team together. They do nothing apart. They do all of their planning together. All of the work is really meant to wrap around that person and prevent that fragmenting of lots of different specialists and services. And so we didn't have a rate in Medicaid that was going to sufficiently cover that service and pay for the good fidelity to that model of a comprehensive team. So what we did is bring in a new rate. Actually, it's a tiered structure of rates that pays for greater fidelity with greater reimbursement. And those that is the other service. We've also found through studies here in Virginia evaluations conducted by DBHDS, that cohorts of folks who participated in ACT over a 2-year period reduced their hospitalization stays by 50%. So we have good data to say that, not just in the national samples, right here in Virginia, that this is a really good alternative to inpatient hospitalization. Heather talked right before me about the really important and exciting work that we've been doing together around the transformation of the comprehensive crisis system. So I won't repeat those services because she did name them, but that is actually a set of services in and of itself. And then multisystemic therapy and functional family therapy are two highly evidence-based practices. Those are the ones I mentioned from the Department of Juvenile Justice. So they exist here in the Commonwealth and have a workforce, but didn't have a Medicaid rate. And so we're bringing those on board. So let's talk about funding for these transformative services. We had some initial budget projections, and then a little thing called COVID happened, and we all went on freeze. And so when we were fortunate enough to be reallotted this money, we were so grateful to get started back. We had really kept all of the irons in the fire, hoping that would happen. And so our teams have really worked very flexibly and in a very committed way over the last 6 months, because we submitted a changed implementation plan that was strategic to let us still get this done over this year period. And so we will be implementing in just a couple of weeks. We are going to go live with assertive community treatment, partial hospitalization and intensive outpatient programs. And then just 5 months later, on December 1st, we will be coming out with that comprehensive crisis timeline to really line up with the work that's going on with DBHDS that you just heard about. And then we will also be bringing on multisystemic therapy and functional family therapy. I do want to make a note of the other intervening factor here. Many of you are familiar with the Families First Prevention Services Act and the work that's being done at DSS and OCS and with all the child serving agencies around that work. They are bringing on multisystemic therapy and functional family therapy on July 1st. So we are aligned with them and have been working to assure that these all these pieces are working together. So I wanted to give you a high-level update of all of the work that our teams have been doing and really give them a lot of credit because they've been working in hyperdrive. We even just this morning, we're in MCO readiness reviews, getting into all of their systems to make sure that all of the systems changes and the service auth processes are well streamlined and are working as intended. That work is going to be done as of this Friday. And that will leave us 2 weeks of troubleshooting. We're working on additional guidance documents based on stakeholder feedback. We're also looking to develop learning collaboratives. So taking the stakeholder groups that we've been around the table with as we've develop the service definitions and the medical necessity criteria for these services, and kind of keeping them in an organized group so that as we move into implementation, this isn't just we implement and close the door. We want to maintain close relationships with them and hear about, what goes wrong, what goes right in the implementation, how can we improve? So we have still some things that are near complete. Actually, I should change some of these because they've changed as of the last 24 hours when these slides were sent over, but the manual has been posted. We're very excited about that. It's on our website and it's live. It went through a town hall posting and we integrated all the comments. We've also recently posted all of our brand new and much improved service authorization postings. Want to give a big thank you to our stakeholders, associations, for looking at those with us and helping us to redesign those in a way that we hope will provide some process improvement. We've also been finalizing internal dashboards at DMAS, where we've been working to develop these over the course of COVID. These will allow us to pull up utilization data, which is on a bit of a delay, but it will allow us to pull that data up in a way that we can sort, filter, look at utilization of services by geography, by demographics, by time periods. It will be a facility with the data that we have not had in the past, and that's going to be really helpful as we bring these new services, enhancing that system to see how that impacts the current services and then what the utilization is looking like of these new services in this complicated world of kind of a COVID reality. So we never really anticipated this implementation was going to take place in this context. But the lesson for us is that they are needed now more than ever. And so we're eager to see how they are integrated into the current system. We have been providing some accreditation and Medicare certification guidance because some of our services are including these requirements this time around. And any day now should have our state plan approval. And then we've completed many of the other preliminary tasks, including orientations to those accreditation processes, all of our IM and system changes, even in the midst of our MES implementation and planning, all of the provider manual trainings for our stakeholders. One of the great benefits that has come out of this very difficult year is our facility with technology. Any of you who ever had meetings with DMAS, I wish I could see all of your faces, you could raise your hands. We had a conference call line that was not ideal. And that was, really the best technology we had as a platform prior to COVID. And it really, it burdened us in terms of being able to have really strong collaboration when not everybody could physically be in the building. Well, we have gotten much more facile with use of Google Meets and WebEx and other platforms. And I've also developed a new website that just went live. And in that website, we've been able to also work on the process of converting all of our trainings, public meetings, all of our documents, all of these things, we've turned them into YouTube videos and then linked those onto our website so that our stakeholders can see them and have access to them. So that's a huge improvement and level of transparency for us, and one that we've really appreciated being able to offer. So we've also put out a number of provider communications and bulletins about all of this, and we feel like everybody is raring to go and we're getting ready on this first round of services for July. Then, we actually technically have already started on some of the preliminary steps for phase 2, but we're gearing up to devote all of our energies to that process over the next 5 months. That will include a coordinated support for the crisis services implementation. And so here, I'm acknowledging all of those different pieces of that puzzle that Heather just mentioned. So we're really, Project Bravo, our piece of this puzzle is at the center for us. What we bring to the crisis picture is that we've been working to develop the service definitions and the medical necessity criteria to align with that crisis now model that Heather cited. So we're really defining the services and providing the rates to allow these services to kind of be lifted. We're also defining them in such a way that is seeking to open them up beyond the CSB system and assure that we have good partnership between the CSB system and our private providers. We need everyone at the table together in order to provide the level of crisis response that's really going to be necessary to make this work as intended. And so, we are very invested in working through that process with our providers and DBHDS, and thinking as we begin to move towards the infrastructure of the call center, and for example, how calls are dispatched from those centers to both CSBs and private providers, to assure that there's kind of an equitable opportunity for participation in this service, but also that everyone is all hands on deck, that we're all in this together, because as we've acknowledged today, we think there's going to be appreciable mental health need coming out of the pandemic. And so having these services, again, be facile and available 24/7 all over the state and for all ages and disability types is really important. So anyhow, we kind of, we're at the center of the kind of service definition and payment structure for these services. And this is really what our concentration is going to be. The multisystemic therapy and functional family therapy process will restart in just a few weeks with bringing those stakeholders back together. I know there's a lot of questions from them right now as they're getting ramped up and ready for the new contracts with DSS and OCS for the Family First Preservation Act implementation. And so we're really wanting to all walk together and make sure that we're, as funders of this service, all working together appropriately with the right kind of funds and for the right kind of eligible folks, and making sure that we just have as open access to these high quality services as we can have right now. DMAS does not hold any current authority to do anything outside of what I've talked about today. So that I would say that's one of the top questions that I get is about what comes next, or what are we working on after this. We are really devoting our full and entire energies on these two phases to make sure that they roll out well, and that this is a success story for everyone involved. There is one exception to that, is that there was a bill and budget language associated with behavioral therapy and bringing on the appropriate ABA codes. So there was budget language for that. So that's another service that's going to see a change on December 1st. That is, in some ways, you could think about that as an enhancement, because there will be new rates for the ABA correct coding. But nothing, it still will be the spirit of the service. It's just that we're changing over to the new way of coding and billing for that service in line with the appropriate coding. So that is all I have for you today, but I'm happy to answer any questions that you might have about this implementation.
Melissa, thank you so much. That is again awesome progress there. I think Mindy Carlin has got a hand up there.
Thank you, Mr. Chairman, members of the subcommittee. I'm Mindy Carlin, the Executive Director for the Virginia Association of Community-Based Providers. I really just wanted to give Alyssa and her team, and DBHDS as well, just huge props for working collaboratively with the private sector. So my association represents private sector community-based providers that all provide Medicaid reimbursed services, and highlight just a few things, particularly the service authorization forms that Alyssa and her team spent a lot of time really looking at the process side of things. I know I've spoken with many members of the subcommittee about the challenges providers face in having more and more and more requirements from the managed care organizations to provide documentation. And so we're really hopeful and look forward to seeing those new forms kind of expanded to all the Medicaid services as we move forward, and that might help temper some of all of that extra administrative work. With respect to Alyssa, Dr. Ward raised the issue of the Families First and CSA being a bit ahead of DMAS with respect to timing on implementation of MFT and FFT, MST and FFT. And that is an area of concern. We're working with Alyssa and her team on this, but the fact that those regs, DMAS regs related to those new services coming online have not yet gone through the process, and yet CSA is moving forward now, is creating a bit of a challenge that we're working through. I also wanted to add, I think Dr. Ward referenced the requirement of accreditation with respect to MHIOP, one of the services that's being implemented. And our members, some of our members are accredited, some are not. For those who are members of the subcommittee who aren't familiar with that accreditation, there's a significant kind of cost and time commitment to becoming an accredited agency. There are accrediting bodies that are outside of, that are national in nature, and they include surveying and lots of oversight and policies and procedures that they be in place, and then they check those. And so our members that I represent, at least, and Jennifer Faison may agree, while we embrace kind of efforts like that to elevate the standards of our members and of our providers, really urge kind of any additional direction that we can get with respect to if that is seen as a requirement specific to that service, or if that's more of kind of a vision that we have to move more Medicaid services in that direction. It's a multi-year commitment to do that with costs. And so that's a question that we've raised related to those accreditation requirements. And then the second piece to that is, how do we look at the requirements that are and the oversight from the Office of Licensing within DBHDS, and having the accreditation oversight be on top of that licensing, and again, moving in the direction of kind of more oversight, more requirements, more as opposed to kind of looking to make sure that we're ensuring high quality, but not duplicating and creating kind of onerous standards on providers that don't allow them to really focus where we want them to be, which is on delivering care in a high quality way. So huge kudos, really. I mean, I can say, based on my experience, we've never had closer coordination and partnership with both DBHDS and DMAS. And I really credit the people on this call for that, and am grateful for that and for your leadership. So thanks, Mr. Chairman. I'm happy to answer any questions, but thanks to all involved.
Thank you, Mindy. I love hearing that. That makes my day to hear that collaboration is working. Any other questions for Alyssa? I'm going to keep us to, we have a 2:50 absolute cutoff, but we do have a few minutes here. If there are any additional questions. Alyssa, I'll throw, oh, actually, I'm sorry, I'll let Jennifer Fedora.
Thank you, Mr. Chairman. And I mostly just want to echo what Mindy said. The input and the opportunity to do that has been really terrific. We do, I think, maybe as a bigger sort of, more global behavioral health effort that you could be, part of or lead or whatever with this subcommittee. We probably do need to step back at some point and look at all the pieces. I mean, Mindy mentioned too, accreditation for each service, and then for the agency, and then licensing on top of that. But, we have on lots of different levels, we keep adding, that's what we know how to do. And, we do that really well. We add on. And so at some point in the next year or two, it might be worth the time to step back and say, okay, what have we done in terms of building the quality of our behavioral health system writ large? And what's reasonable? And are there things that could be taken away? Are there things that could be, fixed so they're not duplicative? And that's a big question. That's not for today, but just put that on the back burner someplace, sir, and add that to your list of things that you have nothing better to do, so you'd love to take on. I'm just sure of that.
I appreciate that, Jennifer. I do. I thought, let's see another hand up. I thought, yeah, Jennifer Fedora. We have several Jennifers here.
Well, yes, and I haven't taken my hand down yet. That was me. Before.
Oh, no, how about Jennifer Faison? Yeah, there we go.
Yeah, and Jennifer as the other one.
Yes.
Or if I'm talking about her, she's the other one. Yeah. It's fine. We're going to take over the world, the Jennifers. Thank you for holding these sessions, first of all, Mr. Chairman, and great participation. And it was really helpful for me, although I think Commissioner Land and I have spent every day together this week so far, and maybe we'll shoot for tomorrow and Friday as well. But it is good to step back every once in a while and look at the progress and really dig into the accomplishments, because all of the things which are occurring, we can talk about them and we can run through them in a slide presentation, but it does take a sustained effort by the folks who are actually having to implement this on the ground. And in many of these cases, with Step Virginia and the crisis continuum, that's going to be your public safety net providers and the CSBs. And so it is good and helpful to step back and look on a broad scale and celebrate the accomplishments and achievements that we have made so far. And I did just briefly want to say, Delegate Hope had asked a question about the ARPA funds, and it's come up here and there. And I think while they are kind of one-time or short-term money, super short-term, the money that's coming to the state that the General Assembly will be appropriating and working with the administration on, I think does have the ability to influence maybe 4 or 5 big areas and relates to all of the work that's going on. But really, I just want to emphasize with this group that workforce is a huge issue, and it's not relegated just to private providers or public providers. It's the entire system. And I do think there are some ways that those ARPA funds can really be used to bolster our workforce and to really staunch some of the bleeding that is occurring and people making different choices. It's many ways this work is a calling. You can't make people want to do it. They just have to want to do it. And so I'm hopeful to, as an association, to advance some priorities in that regard and some of the other bigger system pieces that the association has to the members of this body and to the General Assembly more broadly. Thank you.
Quick comment, and I'm going to flip it to see. We're going to run out of time in just a second here, but to that point, we're going to have our next meeting is going to be on July 14th, and we're going to cover workforce. It's a critical issue. It affects everyone on this call in the whole state, and it's workforce recruitment and retention, and we're going to dive into that with Jennifer Wicker, Jennifer Faison. Will help us work through that as we get into it. And then last but not least, see if you had Delegate Price, you had a question. I think I saw your hand up there. Oh, check your.
Sorry, I just wanted to make sure that we weren't waiting to like the day before special session to have these conversations, especially about the American Rescue Plan funding. So I'm glad to hear that that'll be a part of the conversation. And just for everyone else on the call, just remembering all of the different pieces that are in motion, that conversation about workforce development has also come up for Deeds Commission. So we want to make sure that all of the different players are being updated and just staying mindful of that. That would be wonderful.
Awesome. Well, again, thanks to everyone. Thanks to our speakers, Mira, Heather, Alyssa, thank you so much for joining us today. Thanks for all participants there. I should add Mindy Carlin also is going to be joining us for the next one on July 14th. If there are any other questions you have, Colleen Grady on my team will be glad to take those, and we'll bring them, share those, or cover them next time. Stay well, and we'll keep this conversation going. Really appreciate your time today.
Thank you.